It is my pleasure to introduce Dr. Akshay Kumar, who is one of NGHS PGY3 internal medicine residents. He earned his medical degree from the Dow Medical College in Karachi, Pakistan. Dr. Kumar is interested in hospital inpatient medicine and plans on being a hospitalist after graduation.
Hello, good afternoon, everyone. So today's topic that we're going to discuss is delirium in hospitalized older adults, and this is one of the common challenge we face in hospitalized patients, especially in the older population. They suffer from delirium, and it's complicates their hospital course, prolongs their length of stay, and causes them to get discharged to acute care, post-acute care facilities, and things like that. So we are going to discuss the measures we can take to prevent delirium while patient is hospitalized, and if you are seeing a delirium, how to recognize it in early stages and treat it to prevent those complications. So I do not have any disclosures to make regarding this presentation. So today's learning objectives are going to be identify what constitutes delirium in an institutionalized older adults, how to appropriately assess and manage delirium in acute setting as per the latest guidelines, and measures healthcare providers should take to prevent onset of delirium in hospitalized setting. So I just want to start with a clinical scenario. I wanted to I will read the scenario, keep it in back of your mind, and we'll go through what could have been done to prevent this kind of a scenario as we approach towards the end of our presentation. So a 75-year-old man is admitted for a scheduled major abdominal surgery. He is functionally independent with mild forgetfulness. His intraoperative course is uneventful, but on post-operative day 2, severe confusion and agitation develop. So what is going on? How would you manage this patient's care? And could this condition have been prevented? So just keep it in back of your mind, and we'll discuss further towards the end. So to begin with delirium. So delirium has been described in medical literature for more than 2 millennia, but the condition is still not frequently recognized, evaluated, or managed appropriately. And delirium is also known as acute confusional state, altered mental status, and toxic metabolic encephalopathy. And delirium can also be thought of as an acute brain failure. Officially, the definition of delirium is described by Diagnostic and Statistical Manual of Mental Disorders, 5th edition, that is DSM-5. And the pathophysiologic mechanism of delirium are poorly understood, but proposed theories include neurotransmitter imbalance and neuroinflammation. So delirium is extremely common in hospitalized older adults, and 1/3 of the hospitalized patient population who are aged above 70 or older have delirium usually. And the condition is present in half of these patients on admission and develops during hospitalization in the other half. So our goal is we can't prevent the one who are already coming in with delirium, but our goal should be to prevent delirium who are hospitalized, to prevent them developing a delirium in the hospitalized setting. So delirium is most common surgical complication among older adults, with an incidence of 15 to 25% after major elective surgery and 50% after the high-risk procedures such as hip fracture repair and cardiac surgery. Although many clinicians think of delirium as being agitated, but in contrast, hyperactive delirium only represents 25% of the cases. Rest of the delirium, which is 75% of remaining delirium patients, are hypoactive and quiet delirium. So it's very important to recognize those set of patients, as we often tend to miss those set of patients. So hypoactive delirium is associated with a poor prognosis, potentially because it's less frequently recognized. The features of delirium range from mild to extremely severe, with a greater severity associated with worse outcomes. Risk factors for delirium have been classified into 2 subgroups, like predisposing factors and precipitating factors. So first we will talk about predisposing factor, like older age, pre-existing dementia, functional disabilities, and a high burden of coexisting conditions are common predisposing factors. Male sex, poor vision and hearing, depressive symptoms, mild cognitive impairment, lab abnormalities, and alcohol abuse have also been associated with increased risk. Among precipitating factors, drugs, especially sedative hypnotics, anticholinergic agents, surgery, anesthesia, inadequately managed pain, anemia, infection, any acute illness, and acute exacerbation of chronic illnesses are the most commonly reported that can precipitate delirium in a hospitalized patient. The classical teaching was that delirium is transient, but however, the recent literature is showing that that's not always the truth. Some patients come in, get delirium, they have some little bit of a baseline dementia, and if they get delirium in the hospital, they can have a new baseline and can have kind of a go on and having the persistent delirium. Maybe it can last their however time they live for. So it's important to prevent delirium. Risk factors for persistence of delirium include advanced age, pre-existing dementia, multiple coexisting conditions, delirium severity, and the use of physical restraints, which we see is a common practice, like when we are busy dealing with other patients, somebody is delirious, and we put them on a restraint, so it actually harms the patient in the long run. So we should be careful about using physical restraints and should be using it if it's absolutely necessary and take them out as soon as there is no need for physical restraints anymore. In hospital, delirium is the potent risk factor for complication, a longer length of stay, and discharge to post-acute nursing facility. So diagnosing delirium, so we have two subsets of patient, one in the critical care setting and other in general medical floor. So we use for both of them confusion assessment method. For the ICU, we use CAM-ICU. So we'll discuss both. So confusion assessment method is most useful bedside assessment tool for diagnosing delirium. And we'll discuss what factors we look for when we are assessing via the CAM method. Dementia, depression, and acute psychiatric syndrome should all be considered in the differential diagnosis of delirium. And these syndromes often co-occur and patient may have one or more of those. Severe hypoactive and hyperactive delirium can be confused with depression and mania respectively. So they should be carefully evaluated and diagnosis should be made appropriately. So the diagnostic criteria for delirium, so DSM-5 criteria is presence of delirium requires all criteria to be met per the DSM-5, which is disturbance in attention and awareness. Disturbance develops acutely and tends to fluctuate in severity. At least one additional disturbance in cognition. Disturbances are not better explained by pre-existing dementia. And disturbances do not occur in context of severely reduced level of arousal or coma, and evidence of an underlying organic cause or causes. While the confusion assessment method, the CAM method, requires presence of either feature 1 and 2 or 3 and 4 in combination. So those features are like feature 1, acute change in mental status with fluctuating course, inattention, disorganized thinking, and altered level of consciousness. These are the criteria to diagnose delirium. Once you have diagnosed delirium, how you will evaluate delirium? So newly diagnosed delirium can herald a life-threatening emergency, and affected patients require a prompt and appropriate evaluation, including proper history taking, physical and neurological examination to rule out any stroke or any underlying intracranial pathology, and the lab testing. So when you are dealing with delirium, these are the things you should typically look at, like drugs, electrolyte disturbances, lack of drugs, like if you are not treating their pain adequately, they can go into delirium, or they have been dependent on opioids, you're not giving to them, or sedative hypnotics, you're not giving to them, they can go into delirium because of that. Any infection, reduced sensory input, like if they were used to wearing glasses or hearing aids and you're not having them while they are in the hospital, they can develop delirium. Intracranial disorders, urinary or fecal disorders, myocardial and pulmonary disorders, urinary incontinence, and these are all kind of risk factors for patients developing delirium. And when you're evaluating, you should always be careful and review all these things. So first and foremost cause of delirium is medication. So a thorough medication review is required for all patients with delirium, and this should include consumption of alcohol and the use of non-prescription drugs and dietary supplements. The physical exam should evaluate vital signs including oxygen saturation and the heart, lungs, and the abdomen. Neurologic examination should evaluate any new focal findings that suggest an intracranial cause like a stroke, and you have to rule out the stroke before labeling it as patient is having delirium. Tests that are routinely required include a complete blood count, measure of electrolytes, blood urea nitrogen, and a creatinine, a urine analysis, urine culture, LFTs, chest radiograph, and ECG are also often helpful. Additional lab tests and imaging should be selected on the basis of history and physical exam. Suppose if a patient has focal neurologic findings, you need to rule out the stroke, and in that case, the CT will be appropriate. Otherwise, just for delirium, it's not appropriate to order CT scan. So delirium in ICU setting is a other special subset condition, and delirium is much more prevalent in ICU patients who are on mechanical ventilation, and it's affect up to 83% of patients in the ICU who are on mechanical ventilation. And any new onset of confusion in adult patients in an ICU always warrants further evaluation. And ICU acquired delirium being one of the top differential, as you can see, like 8 out of 10 patients in the ICU will suffer from delirium. So special tools have been validated for appropriately diagnosing delirium in an ICU setting. So how will you assess for ICU associated delirium is the same confusion assessment method, which is specialized for the ICU. So it's called CAM-ICU, and we'll be discussing what it compromises. And the other is the intensive care delirium screening checklist. These are both extensively validated and used for delirium diagnosis and evaluation of delirium over time. And these both tools are simple to implement and allow non-psychiatric ICU personnel to diagnose the complication rapidly and reliably, and can be adopted even when the patient is unable to speak due to intubation. So in a CAM-ICU approach, so it's a two-way approach. In the first one, you assess the level of consciousness and arousal through a standardized sedation scale such as Richmond Agitation Sedation Scale, commonly called RAS. It's a 10-point scale ranging from +4 to -5, where a RAS value of 0 indicates a calm and alert patient, and RAS scores of -4 and -5 are indicative of coma and cannot be further assessed for delirium. All other individuals, like moderately sedated or RAS score of -3 or higher, should also be evaluated through second step, which assesses patient for 4 characteristics of delirium as discussed earlier for CAM method. So the CAM method, as we discussed, includes assessment of acute onset of altered mental status, inattention, disorganized thinking, or altered level of consciousness. 3 out of 4 features are required for diagnosis of delirium, in contrast to in regular patients on the medical floor where just 2 of the features were required. Here you have to have 3 features out of 4. And then the other approach is ICDSC approach. Utilizing this approach, the level of consciousness is first evaluated on a 5-point scale, like from A to E, that ranges from unresponsive being A to exaggerated response E. Patients who are scored in categories A, which is no response, or B, which is response to intense and repeated stimulation, are not further assessed. And the patients who have level C to E level of consciousness are checked for information collected during the previous 24 hours and investigating 8 items, which we'll be discussing shortly, with a total score of 0 to 8. A score of 4 or greater is considered diagnostic for delirium. So these are the factors in intensive care delirium screening checklist we are using to score patients from 0 to 8. If the score is 4 or above, definitely patient is delirium. The higher the score doesn't mean the patient has it doesn't correlate with the severity of delirium. It's just above 4 is delirium, that's it. So management of delirium, once you have diagnosed and evaluated the causes of delirium, is well integrated care by the physician, nurses, and other providers, and even family members, helps to prevent complication and poor outcomes often seen in delirium. Medications are most common modifiable contributors. Common precipitating medications and potential are benzos, opioid analgesics, non-benzo sedative hypnotics, like a lot of people are on Ambien nowadays for sleep, so that can contribute to delirium. Antihistamine, especially first generation antihistamine, which has anticholinergic effects. Use of alcohol, anticonvulsants, anticholinergics itself, tricyclic antidepressants, antihistamine, anti-Parkinson drugs, antipsychotic, and barbiturates can all cause delirium. Environmental factors are also important in delirium management. The hospital ward should be well lit during the day and dark and quiet at night. Interventions to improve orientation and reduce the sensory deprivation include clocks, calendars, and encouragement of patients to wear glasses and hearing aids if they are used to wearing those in their home setting. And family members should be encouraged to visit and provide orientation and reassurance to patient. Monitoring of bowel and bladder output, preferably without urinary catheters unless required for treating urinary retention. The constipation can be prevented by judicious use of laxatives, and prophylaxis is essential in those with standing orders for opioid analgesics. Getting the patient out of the bed to chair, preferably walking, can prevent atelectasis, deconditioning, pressure ulcers, as well as helps with prevention of delirium. And some patients with delirium may require aspiration precautions and monitoring too, if they develop delirium. So first and foremost method of managing delirium is non-pharmacologic interventions, or the cornerstone for managing behavioral problems in delirium. Nurses should be trained in de-escalation techniques, and when necessary, sitters can be employed to ensure patient safety rather than putting them on a restraints or using antipsychotics to treat their delirium. Physical restraints, which staff often use to reduce the risk of patient self-harm, are actually associated with increased injury. So in the ICU setting, restraints may be required to prevent removal of endotracheal tubes, intraarterial devices, and central venous catheters or lines. If the restraints are must and they are applied, they should be carefully monitored to reduce the risk of patient injury and discontinued as soon as they are no longer indicated. That is why we have to keep on renewing it every 24 hours. The purpose is to just make sure that they don't need it. But a lot of us, we usually just renew it as per the nursing discretion. So we have to go and assess the patient and make sure that if they need it or they don't need it. Pharmacologic treatment may be required for distressing perceptual disturbance or delusional thoughts when verbal reassurance is not successful, or for behavior that is dangerous to patient and others. And benzos should be reserved for specific conditions, like if delirium is associated with alcohol or benzos withdrawal, then those are appropriate to use benzos. Otherwise, in all other conditions, it's almost always wrong to use benzos to kind of a calm patient down who is delirious. For the other cases of delirium, antipsychotic agents have a more favorable risk-benefit ratio as compared to benzos. However, all such use in the USA is off-label use, and there are no any FDA-approved medications to kind of help with a delirious patient. Haloperidol, or commonly goes with the name Haldol, is the least sedating but has the greatest risk of extrapyramidal symptoms, so you definitely don't want to use it on a patient who has a Parkinson. Whereas quetiapine, commonly goes by the name Seroquel, is most sedating and has the least extrapyramidal effects. And the patients with prolonged delirium may need continual scheduled dosing, like once, twice, or thrice a day, as with physical restraints, because these are not FDA approved and are used for short-term acute measures. These drugs should be stopped as soon as possible. So at the first place, how you can prevent patients from developing delirium. So frequent reorientation and presence of family members, a non-pharmacologic sleep control, getting the patient out of the bed and walking, encouraging the use of eyeglasses and hearing aids, as well as encouraging fluid intake are the measures to prevent from then going into delirium at first place. Another effective non-pharmacologic approach for delirium prevention is proactive geriatric consultation in surgical patient at high risk for delirium. Unfortunately, we don't have inpatient geriatrics consultation on a lot of our patients. So that is a thing that can be changed, which will prevent delirium in older adults, especially who are post-surgical patients. And a structured protocol is used to formulate daily recommendations, for example, using round-the-clock Tylenol and local pain management to reduce opioid use, and discontinuing standing orders for sleeping pills. Geriatrics orthopedic services have been widely adopted for patients with hip fracture to reduce incidence of delirium. In studies done so far, there is no any clear evidence that use of melatonin or melatonin agonist reduces the incidence of delirium as compared with placebo. So coming back to our clinical scenario, as we discussed, a 75-year-old man is admitted for scheduled major abdominal surgery. He is functionally independent with mild forgetfulness. His intraoperative course is uneventful, but on post-operative day 2, severe confusion and agitation developed. What is going on? How would you manage this patient's care? Could his condition have been prevented? So based on what we just discussed, so this patient is suffering from severe hyperactive post-operative delirium. And after confirmation of the diagnosis, the next steps should be conducting a careful evaluation for reversible causes and addressing as many of these as possible. Agitation should be managed with non-pharmacologic strategies first, as just discussed. Physical restraints should be avoided. Antipsychotic agents should be reserved for unremitting symptoms that threaten the patient's safety, and if required, Haldol with initial dose of 0.25 mg. Zyprexa 2.5 mg, Seroquel 12.5 mg would be reasonable first choices, and depending on the amount of sedation desired. Had this patient's mild forgetfulness been recognized preoperatively, he could have been identified as being high risk for delirium, and proactive strategies could have been implemented to reduce the risk of patient going into delirium. So the next slide will do a quiz. So 85-year-old man is evaluated in the hospital after surgical fixation of a broken hip. He reports a mild level of pain. He did not bring his glasses or hearing aids to the hospital, and he has been making progress with physical therapy, and when his pain is controlled, he will be transferred to inpatient rehab facility. His history includes high-frequency hearing loss, macular degeneration, and hypertension. Medications are lisinopril and chlorthalidone. On physical exam, vital signs and other findings are normal. Which of the following is most appropriate measure to prevent delirium in this patient?
So who would like to answer? I'll hand you the microphone. Oh, here we go.
E, because he will need his glasses and hearing aids to be able to be oriented to whatever is happening around him.
Correct, yeah. So as discussed that sensory input deprivation can lead to delirium, and to prevent this, if they are used to wearing the eyeglasses or hearing aids in their home setting or wherever they're coming from, we should kind of provide it to them when they're in the hospital setting. So the correct answer is E, the patient's glasses and hearing aids should be provided to him to prevent delirium. And identifying and correcting the sensory impairments, including providing patients with their visual and hearing aids, is effective in prevention of delirium. So second question, 78-year-old woman is hospitalized for pneumonia. Appropriate antibiotics were initiated and a urinary catheter was placed. The patient has a history of dementia and her only other medication is donepezil. On physical exam, temperature is 100.1 Fahrenheit. Other vitals are stable. The patient appears stable but is disoriented. Crackles are present in the left lower posterior lung field. Neurologic examination reveals cognitive impairment without inattention or evidence of focal neurologic deficits. Which of the following is most appropriate next step to prevent delirium in this patient?
What did you say? You have to use the microphone. Who said it?
I believe D, urinary catheter removal.
Mm-hmm. And why is that so?
Because UTI in a hospitalized patient is one of the most common causes of delirium in elderly. So if we can prevent that, then...
Right, yeah. That is one of the reasons as well. Urinary catheters can predispose patient to UTI. But the other thing is that any external device attached to a patient can cause them to go into delirium. So the most appropriate next step to prevent delirium in this patient is urinary catheter removal. And non-pharmacologic measures that reduce the risk of delirium in patients include removal of catheters such as bladder catheters, restraints, cognitive reorientation. Even the patients who have a central line, as soon as it's not needed, it should be pulled out because it risks patients going into delirium. Sleep enhancement, early mobility, and adaptations for visual and hearing impairment, nutrition and fluid replacement, pain management, appropriate medication use and adequate oxygenation, prevention of constipation, and family or sitter at bedsides are all the measures taken to prevent delirium in hospitalized patients. The use of antipsychotic medication in elderly patients with dementia is associated with an increased risk of death, stroke, and MI. So just be careful and don't load patient with antipsychotic unless absolutely necessary. These are the references for my presentation. And I would like to thank my mentors and reviewers, Dr. Carr, Dr. Newcomb, and Dr. Jacob. And thank you all for attending. If you have any question, I will open platform to you.
Excellent. Thank you, Dr. Kumar. If you're viewing online and you have a question or comment, you can enter it in the Q&A chat. And then in the room, I'll hand you the microphone.
Hey, Dr. Kumar, thanks for your presentation. Question for you. You mentioned the possibility of doing early geriatric inpatient consultations to help with prevention of delirium. Have you come across any evidence that actually helps?
So I was just reviewing the articles, and in the big academic settings where they have an inpatient geriatric services, they usually are able to kind of identify the drugs. Like mostly the patients who have a geriatric consultation are the surgical patients undergoing major surgery like hip replacement or hip fracture surgery. So those patients benefit from geriatric consultation. They are able to identify the medications and they reduce the dose, and they kind of post-surgically they come up with a plan for pain management and things like that are not associated with delirium. So yeah, in literature it was found that big academic centers who had an inpatient geriatric consultation did have a better outcome compared to the hospitals where it was not performed.
Thank you. We have one down here.
Oh, yeah, of course. Thanks, Akshay. Great presentation.
Thank you.
What's the role of VR in preventing delirium?
So I know it's kind of undergoing investigation, and it's in the like one of our senior who is graduated now was doing that project. I don't know whether he was able to analyze the data post implementation of the VR or not, but I didn't come across much literature because it's still in the early stages of development. But I think it's definitely, if we are reorienting them with the help of VR, simulating their home environment, it will be definitively helpful to prevent delirium in those settings.
And are we using the VR?
I think when Dr. Chu was here, he was implementing it in the ICU, but I have not been in the ICU recently, so I'm not sure. Maybe somebody who has been into the ICU recently can shed light on it.
Okay. Yes, he did a presentation a few months ago about that. I remember. We have a question over here.
Great presentation. So my question is, say someone has delirium on the floor. You said the first line is non-pharmacologic therapy. So as far as your research or what you found, what's the first thing to do non-pharmacologically? Is it a sitter or is it just reorientation by the nurse?
So the first and foremost thing is to identify the cause of delirium, like why the patient is delirious, and identify and fixing that cause. After that, if the patient safety and the staff safety is at risk, then employing a bedside sitter is the second best option. Otherwise, just making sure that we are providing them frequent reorientation, having family member at the bedside also helps, and removing any unnecessary devices or catheters is also helpful.
All right. Thank you, Dr. Kumar.
Thank you.